Ah, the United States Civil War, a 4 year period of bloodshed that began after a few southern states had slightly differing views of the direction that the political future of the then young US of A should take. A vicious battle for sure. And it seems like one of the casualties of war is being carted off now with what looks like a pretty bad belly wound. Painful. But let's think of this guy as our clinical case. Jim here is a young 22-year-old male who's been having this crampy lower abdominal pain for the past 24 hours. When asked where it is, he points at his right lower quadrant. He's had similar episodes of this in the past that just go away on their own, but never this bad. His past medical history is pretty minimal, but he does state that he's always had stiffness and pain in his joints, specifically his shoulders, hips, and knees. He's never had it checked out by a professional, attributing it to playing sports as a kid. Of note, he denies a previous history of abdominal surgery. He also reports that he's had a low grade fever going on. With this constellation of symptoms, he practically tells us that he knows it's appendicitis and that he knows he's going to need to go to surgery for it. His sister had the same symptoms a few years ago, and she had to have her appendix out. Okay. I don't think those little blue baggies have been invented yet, but this guy sure seems to need one. He's having plenty of nausea and emesis. He's literally green. And now his abdomen looks distended. He also reports initially having diarrhea, the really watery kind, but that stopped and he hasn't had either gas or stool in the past 12 hours. He's no stranger to all of this, though. Sounds like Jim here has had plenty of episodes like this in the past. He describes these as crampy abdominal pain associated with diarrhea, but he also reports at other times he's had pretty bad constipation. However, he says they've never brought him to the field medics, emergency room, like this. He thought these were kind of normal until this one. Whoa there, soldier. Can we at least wait until we're inside the medical tent to commence with the rectal exam? But since we already went there, we should point out that there wasn't any blood on exam, but there were these skin tags kind of all around you know, the area. All right. So if we weren't in 1862 America, but say, I don't know, present day, what might you do with a patient with these findings? Right lower quadrant abdominal pain, fever, diarrhea. Uh, cut, move people. It's got to be appendicitis. Get that thing out of there. Ugh. Or or is it? We were asked what the most likely underlying disease is. So, not the best question, but it does make you think. Hold your horses. Put down those scalpels. It turns out that young males with the condition we're going to talk about are often confused with having appendicitis. Spoiler alert, it's not appendicitis. What could it be? All right, a soldier, or any patient for that matter, in their 20s with a history of intermittent crampy abdominal pain and diarrhea, with or without perianal skin tags, should raise a red flag in your minds for inflammatory bowel disease, or IBD. IBD is generally diagnosed as either Crohn's disease, as in our clinical case patient, or ulcerative colitis. Though 15% of cases actually have findings suggestive of both Crohn's disease and ulcerative colitis and are labeled as indeterminate IBD. Since we are suspecting this as a diagnosis, we should probably take a moment to remember the pathological features of IBD, and specifically Crohn's disease. We'll come back to the clinical case in just a little bit. But I want to take this segue because I have this feeling in the pit of my stomach that the diagnosis of our clinical case patient just might be one of the IBDs. But we're not quite ready to make the diagnosis yet. Hang on a minute. Is this feeling in my belly the rumblings of impending knowledge, or is it just an impending bowel movement? Guess we'll have to wait and see. Remembering back to your pathology lectures, Crohn's disease causes transmural inflammation of the bowel, meaning it involves all layers of the bowel wall, which is why this burning wall is damaged the whole way through. Sometimes even the mesentery becomes involved, and the body's response is to form creeping fat in an attempt to cool down all that intense inflammation. This is in comparison to ulcerative colitis, where the inflammation is limited to the mucosa and submucosa. Another important feature of the inflammation in Crohn's disease is the formation of non caseating granulomas throughout the whole GI tract. So we've brought back our recurring macro cages next to the wall to help you remember these granulomas, which these guys are using to store their cannonballs in. Well, I guess macrophages really do eat everything. And when I say throughout the whole GI tract when talking about Crohn's disease, I really mean the entire GI tract. The clever slash disgusting adage you'll commonly hear is that Crohn disease affects anything from the mouth to the anus, hence the mouth and anus archways you see here. Well, isn't that a creepy saying that instantly provokes flashbacks of a certain film named after a human bug hybrid with roughly 100 legs? Oof. Anyway, inflammation in Crohn disease can involve anywhere from the mouth and esophagus, to the small bowel, to the colon, and right to the rectum and anus. Although, interestingly, the rectum is often spared. In ulcerative colitis, on the other hand, inflammation is retained within the colon only, hence the name colitis. If you can imagine that this path is the path of the GI tract, then you can see where the small bowel, specifically the ileum, joins into the colon, the location which we call the terminal ileum. Involvement of the terminal ileum is by far the most common presentation and is seen in about 80% of cases. The inflammation in Crohn disease isn't continuous, and instead shows up as multiple, very clearly separated areas of disease. These non continuous areas of disease are referred to as skip lesions and are highly suggestive of Crohn disease. Again, let's contrast this with ulcerative colitis, where the inflammation is continuous and doesn't typically involve normal areas of mucosa in between inflamed areas. In Crohn disease, deep ulcers also form in a nonlinear, meandering pattern, leading to a very classic cobblestone appearance of the GI mucosa. Full disclosure, the precise etiology of IBD is not fully understood. Although most proposed mechanisms involve a complex interplay, between genetic susceptibility, abnormal gut bacteria, inherent intestinal epithelial defects, a hyperactive immune response, yada yada. Ultimately, we don't know what causes it, but we do know what to look for. The age of onset of most cases of IBD is between 15 and 40 years. So, relatively young people, as is Jim in our clinical case from the beginning. See, I told you we'd come back to it. Crohn disease is also more common in individuals with Jewish ancestry and in white patients compared to black and Hispanic populations, and especially is more common in patients with a positive family history. The typical symptoms of recurrent intermittent diarrhea and abdominal pain can be mild, and can be passed off for years by both the family and the patients as just indigestion, or a picky eater, or food intolerances, and can go unchecked for a while. Usually there's a big flare up of the disease, resulting in a classic presentation of the patients to the emergency department. So, what do these patients look like when they come in the door? The common presenting symptom of Crohn disease are in line with what you'd expect from a systemic inflammatory disease affecting the bowels: low grade fever during a flare up, slow weight loss due to loss of appetite during the recurrent flare ups, and especially crampy abdominal pain and diarrhea. Because involvement of the terminal ileum is so common, abdominal pain in Crohn disease tends to be more localized to the right lower quadrant, as is the case for our friend Jim from our clinical case. What's so important about this? Remember how y'all wanted to cut on this poor feller here at the beginning because you thought he had the side sickness? Appendicitis, I mean. Probably shouldn't try and be a cowboy. Poor guy. He had even convinced himself that this was appendicitis. It's certainly important to rule out appendicitis in these cases, and vice versa, to rule out Crohn disease when suspecting appendicitis. A history of abdominal pain and diarrhea, just like in our clinical case, should make you think Crohn disease is the diagnosis rather than appendicitis, where the pain is new and is only sometimes associated with diarrhea. The weight loss happens gradually from chronic lack of appetite, whereas folks with appendicitis tend to have newer loss of appetite and won't typically lose weight from it. Keep a sharp ear out for more findings that point you away from appendicitis as we keep talking. And seriously, you're gonna want to clean your shoes after walking through those particular puddles. While patients with Crohn disease commonly test positive for occult blood and stool on rectal exam, symbolized here with our recurring Guy's Lounge matchbook for a guaiac positive stool test, gross hematochezia or melena in these cases is uncommon. With ulcerative colitis, patients may have frankly bloody stool. Rectal exam may also demonstrate multiple perianal tags or other perianal disease such as fissures, fistulas seen as sinus tracts, abscesses, and stenosis. More about all of these later. Okay. So, given everything we've discussed so far, I'm sure you've figured out that the diagnosis of our patient from our clinical case is probably Crohn disease. So, that's the answer to the question. But I'm left feeling unsatisfied. Crohn disease may be the underlying disease, but seems like something else is going on. He's not only got the abdominal pain, but his abdomen is distended, there are no bowel sounds, he hasn't passed gas or had a bowel movement in 12 hours. Sounds like a complication, and we're not quite done. Before we get to discussing the complication, however, let's finish up talking about uncomplicated Crohn disease. First, how do we confirm that it is, in fact, Crohn disease? Patients who come in with abdominal pain and diarrhea usually have an abdominal radiograph or CT. But the findings of inflammation are nonspecific and can be seen with many inflammatory conditions. Colonoscopy, however, combined with tissue biopsy, is important in confirming the diagnosis, demonstrated by this guy poking something down his very colonic looking gun barrel. This is where you'll see those pathological signs that we talked about at the beginning: the skip lesions, the cobblestoning, non caseating granulomas, and the disease involving the whole GI tract. Biopsy is where you can see that the inflammation is indeed transmural. Patients with prominent upper GI symptoms, such as odynophagia or severe reflux symptoms, may benefit from concurrent EGD as well. Neither colonoscopy or EGD should be performed in acute flare ups of the condition or if there's concern for bowel perforation or obstruction. More on that later when we discuss complications. Something about Jim's presentation from our clinical case makes me think we should hold off on these exams for now. Interestingly, anti-Saccharomyces cerevisiae antibodies are sometimes found in the serum of patients with Crohn disease. So we've brought back this Saccharomyces bindle sac, a recurring symbol. While they won't give you the diagnosis, they can sometimes help differentiate Crohn disease from ulcerative colitis when patients have indeterminate IBD. Uncomplicated Crohn disease is generally managed medically. Steroids are first line for acute flare ups of uncomplicated Crohn disease and should be initiated as soon as the diagnosis is confirmed. Once the flare is over, patients are transitioned to chronic therapy. There are really two schools of thought on how to do this. The old way is the step up approach, treating using the lowest potency drugs, typically starting with budesonide first line, and progressively adding increasingly potent drugs until remission is achieved. This is typically used for low risk, uncomplicated, mild cases of Crohn disease. The second is a top down approach, which we'll get into in just a moment. Another note on chronic steroid use: a patient's remission may become dependent on steroids, and stopping even temporarily may incite a Crohn disease flare. 5-ASA agents such as sulfasalazine or mesalamine are also used as chronic therapy for mild cases and are considered mid level in terms of potency. Finally, in more severe or treatment resistant cases, immunomodulators such as azathioprine, thiopurine, or the anti TNF drug infliximab may be used, sometimes in combination with steroids as needed. When more severe or treatment resistant cases are encountered, treatment may be established in a top down approach, where the more potent drugs are used first, specifically biologics and immunomodulators, prior to a patient becoming dependent on steroids. Okay, so what happens when medical treatment isn't enough to prevent the complications of Crohn disease? Let's take a look at these one by one and see if and when surgery is necessary. Let's remember back to our clinical case, Jim. He's got a lot going on, more than just your average Crohn disease flare. While starting steroids is important for treatment of the flare, we can't stop there. More worrisome for this next complication in Jim's presentation is his nausea, emesis, and abdominal distension. You know what I'm thinking? I'm talking about small bowel obstruction, of course. Flare ups that result in small bowel obstructions may present with abdominal distension, nausea, and emesis, as well as a lack of flatus, the fancy word for farts, or bowel movements. The combination of these last two is termed obstipation. This is describing Jim, our clinical patient, to a T. Upper GI radiography with small bowel follow through would be a perfectly appropriate next step in a patient with nausea, vomiting, abdominal pain and distension, and other signs of obstruction. On radiography, you would see multiple distended bowel loops, air fluid levels, and tapering of contrast, which is a finding that indicates a transition point. In patients with small bowel obstruction due to Crohn disease, the transition point is commonly in the right lower quadrant, specifically the terminal ileum. We've demonstrated this here with the path obstructed sign at the end of the terminal ileum, and the path being tapered to an end by those rocks and walls. Turns out, small bowel obstructions are the most common surgical complication of Crohn disease. Why? The chronic transmural inflammation of the bowel with flares and relapses leads to the formation of bowel fibrosis and strictures, which, in turn, leads to bowel obstruction. So this is what's going on with Jim. I feel so much better that we found out what's going on with him. Don't worry about that guy. For more details on small bowel obstructions in general, head over to our skateboard park sketch on small bowel obstructions. In fact, the diagnosis of Crohn disease may often follow the workup of a small bowel obstruction in patients fitting the demographic. Upper GI study with small bowel follow through is performed by giving the patient oral contrast, seen here with this guy drinking his alcohol, or, contrast, and taking abdominal x rays at specified intervals to follow the contrast through the bowel. Besides the typical findings of obstruction, such as air fluid levels and bowel dilation, there is marked bowel wall edema and stricture formation, especially in the terminal ileum. Narrowing of the terminal ileum from chronic stricture formation, edema, and inflammation leads to the string sign on x ray, where the terminal ileum looks much more thin than the rest of the small bowel proximally. String sign is highly suggestive of Crohn disease. It's such a buzzword for Crohn disease that we've sketched in this medic tightening the strings on this poor gunshot victim's bandages. Briefly, the initial treatment once small bowel obstruction is diagnosed is going to be NG tube decompression, bowel rest meaning NPO status, serial abdominal exams, and waiting patiently until the obstruction resolves, if it resolves. So that's what we can do for Jim from our clinical case. Better get him on steroids too. An important point to make is that with all that chronic inflammation, a patient with Crohn disease makes a very difficult patient to operate on. There are adhesions everywhere. The bowel is all inflamed and friable, meaning it can get damaged with even the lightest touch. And surgery in these patients causes even more strictures to form down the road. For these reasons, surgeons often delay operating as long as possible until their hand is forced, either by severe obstructions that don't resolve with medical management, or worse, if there's perforation and peritonitis. In many cases, the strictures formed in Crohn disease will grow larger and larger with recurrent cyclical inflammation until they require bowel resection to relieve severe obstructive symptoms. Over time, with multiple strictures causing multiple obstructions, this could lead to the loss of a lot of bowel length. Demonstrated here by this guy cutting himself free of so many loops of rope. So, surgeons developed another procedure to prevent the need for resecting so many loops of bowel. A procedure that can be performed to relieve stress without having to remove the affected bowel is called strictureplasty. This is when a symptomatic stenotic area of bowel is opened longitudinally and then simply closed transversely. The result of this maneuver is that the lumen becomes wider. This can open up bottlenecking strictures in the bowel without having to cut it out. That about finishes up obstruction. Thankfully, Jim from our clinical case is doing well with his steroids and NG tube and bowel rest and has even started passing gas. Good thing we were able to avoid surgery in him. We'll get him on more chronic medical therapy moving forward. Moving on to the next complication. Ugh, right in the skunk water latrine drainage pond. Gross, man. Chronic inflammation and microperforation in Crohn disease may lead to fistula formation, which is an abnormal connection between two epithelialized surfaces: bowel to vagina, and even bowel to abdominal wall. A common fistula symbolized here is the colovesical fistula, which is a connection between the colon and bladder. Patients with colovesical fistulas typically have air in their urine, pneumaturia, stool in their urine, I call that gross, but it's also called fecal urea, and recurrent UTIs, symbolized by that little green bacteria chilling on the water canteen. So, this is stool stained, bubbling skunk water. Wait, is that coming out of his canteen? Ugh. Actually, see where this path is connected to the pond. And remember how we said the path is supposed to be the GI tract? And see that poop, or mud, coming out of the path into the pond? That's just like a colovesical fistula. Involvement of the anus, which occurs in up to 45% of patients with Crohn disease, may lead to formation of skin tags, painful fissures, fistulas, perirectal abscesses, and even anal stenosis. Perirectal abscesses occur in almost half of all patients with Crohn disease. Fluctuance, tenderness, erythema, and swelling may be found on the perineal exam and most likely indicate a perirectal abscess. Abscesses must be drained in order to prevent spread of infection and promote healing. Note: if given the choice between drainage of an abscess with antibiotics versus just antibiotics alone, always go with drainage. Abscess drainage can be achieved by simple incision and drainage or by percutaneous catheter drainage. Fistulas require a bit more attention. A typical fistula in ano, or anal fistula, is formed when an abscess fails to completely heal, leaving behind an open tract that connects an anal crypt to the external skin. Treatment of fistulae are complex in patients without Crohn's disease. However, since perianal disease is most often recurrent in Crohn's disease and multiple operations could lead to incontinence, treatment of perianal fistulas in Crohn's disease is usually medical, with surgery reserved for severe cases or those refractory to medical treatment. Fissures are deep anal ulcerations and have multiple causes. While the most common location in patients without Crohn's disease is the posterior midline, for patients with Crohn's disease, these are more likely to be found on the lateral parts of the anus. Most resolve spontaneously with conservative measures such as sitz bath, stool softeners, and keeping the area clean and dry, though in rare cases, sphincterotomy may be required. In addition to all the findings within the bowel, there are also a myriad of extraintestinal manifestations in Crohn's disease, such as perioral aphthous ulcers, uveitis, arthritis, which turns out is the most common of the extraintestinal manifestations and is typically HLA-B27 positive, renal stones, and skin changes, including erythema nodosum, which is a painful erythematous nodular rash, and pyoderma gangrenosum, which are large ulcers that appear infected but are actually sterile. These are both commonly found on the legs. Primary sclerosing cholangitis may also occur in patients with IBD, including Crohn's disease, but there is a very high association with ulcerative colitis specifically. The cause is unknown but felt to be immunopathologic in nature. Patients may also experience malabsorption and weight loss due to chronic inflammation of the regions of the small bowel involved with nutritional absorption or form multiple bowel resections. Megaloblastic anemia is a specific example of these malabsorption syndromes and results due to B12 malabsorption in either the diseased or resected terminal ileum. All right, friends, let's finish up with a summary. Inflammatory bowel disease should be suspected in patients with a history of chronic intermittent crampy abdominal pain and diarrhea, which alternate with constipation. Pathological features of Crohn's disease include transmural inflammation, non-caseating granulomas, skip lesions, and involvement of the whole GI tract rather than just the colon. In particular, the terminal ileum is commonly involved. Patients with Crohn's disease are typically younger and are of Caucasian or Jewish descent. During a flare, patients may present with fever, abdominal pain, particularly in the right lower quadrant, and diarrhea, which may be mistaken for appendicitis, but may also have a history of chronic colicky abdominal pain associated with diarrhea, may have perianal findings including anal tags on rectal exam, and positive stool guaiac test. Colonoscopy with biopsy should be used for confirming the diagnosis, and EGD may be used if there are upper GI symptoms as well. Initial treatment is typically steroids for a flare up, with chronic management being either a step up approach, starting with steroids and adding 5-ASA compounds as needed until remission is achieved, and then adding biologics or immunomodulatory drugs last if no remission is achieved with less potent drugs. Or chronic treatment may be approached from top down for more severe cases, starting with the biologics and immunomodulatory drugs. The most common complication of Crohn's disease is small bowel obstruction from stricture formation. This may be diagnosed on upper GI radiography with contrast, and may show evidence of air fluid levels, tapering of contrast at a transition point, most often the terminal ileum, bowel wall edema, stricture formation, and lumen narrowing, including string sign. Surgery should be performed as last resort in patients with Crohn's disease and may require extensive bowel resection. Another surgery may be performed prior to the development of obstruction, called strictureplasty, to widen the lumen that's been compromised by the stricture. Colovesical fistula is another complication of Crohn's disease, and other intra-abdominal and extra-abdominal fistulas may also result. Colovesical fistula presents with pneumaturia, fecal uria, and recurrent urinary tract infections. These must be treated surgically. Perianal disease is also common in Crohn's disease, and includes perirectal abscesses requiring incision and drainage, perianal fistula, which are typically treated medically, and anal fissures. Extraintestinal manifestations of Crohn's disease include perioral aphthous ulcers, uveitis, arthritis, renal stones, and erythema nodosum and pyoderma gangrenosum. Other clinical findings in Crohn's disease may be primary sclerosing cholangitis, malabsorption syndromes such as megaloblastic anemia or iron deficiency anemia, and chronic weight loss. Hang on, how come everyone is packing up? They're just tossing their guns on the ground and running for cover. Wait a minute. This is just a reenactment? What the fuck?